Hello, I'm George Dangas from Mount Sinai, and I had a great pleasure to join you today regarding a very interesting and controversial subject, the TAVR antithrombotics in 2020. And we can go right in the presentation. These are my relevant disclosures. And in general, the subject of antithrombotics after TAVR is intertwined with the risk of stroke around TAVR or in general in the TAVR population. These patients are elderly, they have many atherosclerotic risk factors and an ongoing risk of CVAs or other ischemic thrombotic events due to this region. And on top of that, they have a lot of atrial fibrillation, either long-standing, subclinical, or clear new onset perioperatively. This, as we know, the atrial fibrillation is very frequent after surgical aortic valve replacement, maybe about a third or a quarter of the patients, and it's around 10 or 15% after TAVR, or maybe I would say 5 to 15%, average 10-11% after TAVR, but clearly a bump that related with increasing events. The new aspect of the aortic valve is essentially an imaging-based and created a new entity. The reduced leaflet motion, but we can see by the CTA and not at all well by echo, gave interest and a lot of anxiety early on because obviously having microclots sitting on the leaflets of the aortic valve doesn't seem very reassuring to anyone. Particularly the difficult part of this interesting finding was that it's not really related with a bump or a jump in the echo gradients across the valve. Hence, it was really emerged as an imaging finding up front. A lot of theories around the valve thrombosis have been created over the years. We have summarized those in a category of intertwined three types of factors: the surface factors, with an incomplete prosthesis endothelialization being the leading one, hemostatic factors that are related to patient blood, hemodynamic factors related to the overall CHF, other hemodynamics, as well as the change of those hemodynamics with a TAVR. If all those are intertwined in not such a good way, we may have unfortunate events appearing. And those have been documented also in surgical aortic valves, just to be very, very clear. And there is an aspects of degeneration as well as thrombosis around these valves. And this imaging has also been a little bit confusing between the two. And there's a theory that a lot of thrombosis start as such, and then they progress to a bioprosthetic degeneration and dysfunction over the years. Let's go a little bit to new data that we reviewed within the past 12 months or so, particularly the fact that this phenomenon of the valve thrombosis on the leaflets of the TAVR and SAVR is actually fluctuating regardless of any therapy we give. This is one of the two studies in the interest of time. This is with a SAPIEN valve. There was a similar results with a core valve type self-expanding prosthesis in 2020 that indicate that patients imaged blindly to the medical therapy at 30 days and at 1 year. Those who had some by 1 month did not by 1 year, and vice versa. Patients who did not have clots by one valve did develop by 1 year, and in general by 1 year there was about even about a 20% perhaps in between both types of valves, surgical or aortic, with some minor differences in general. But the most interesting finding was indeed the fluctuation of this phenomenon, regardless of the therapy that we give. And indeed, there are isolated reports that all sorts of therapies, particularly anticoagulation therapies, may have resolved some of these clots that were appearing. And as you can imagine here, in very diverse examples in one or more of those leaflets. And you can see how beautiful this phenomenon is imaged by CT. Hence, the very increased anxiety this created when it first appeared. Let's go and see what data we have in patients without, and then later on patients with underlying oral anticoagulation need. First of all, in patients without, we have indicated in the trial, the Bravo trial early on, that the clopidogrel loading may be more of a burden than a benefit. This was in a non-randomized trial, and you can see it was associated with increased vascular complications. It didn't really offer much. Did this pan out in the clinical studies? Well, apparently, yes. This ARTE trial indicated in a randomized fashion, just about 200 patients. There were a couple of more initial randomized trials from Italy of about maybe 50 or 100 patients per group or altogether. Very small one. And then everybody preloaded here with clopidogrel before the TAVR. And in comparison between aspirin monotherapy of dual antiplatelet therapy, and you can see with the follow-up of all the way up to 6 months, all the activity was within the first few days and the first month, and no real difference between bleeding and between the ischemic events, but clearly a lot more bleeding with clopidogrel. This panned out again in 2020 in the POP-TAVI cohort A group that is included a 3-month follow-up with clopidogrel versus aspirin monotherapy, and then at 1 year assessment of all the events. So every patient received aspirin monotherapy between 90 and 360 days, and anyone can see that the activity was all within the first few days, again, mostly driven by the initial loading dose, in my view. Interestingly, you can see the data of aspirin and clopidogrel all the way to a year, and again, you can see a lot of activity in the initial days, but then on you can see further down the line, particularly beyond 6 months, an updrift of events in the aspirin monotherapy. And there's the first time a study like that introduced this factor, and one may say that A, this is a 100% chance, or B, if you are indeed not inhibiting aggressively the first few months after the procedure, maybe events will emerge later on. This is a hypothesis, but again, this is a small study with about 300 patients per group as well. And this is the first time we see follow-up after initial 90-day treatment ending. And the first time, again, we see that there's a significant updrift of events in the aspirin monotherapy group between 3 and 12 months of therapy. In the Galileo trial, we tried to approach this phenomenon with a different pathway, utilizing a combination of a low dose or a medium dose anticoagulation with rivaroxaban 10 milligrams. As you all know, the AFib full dose is 20 milligrams daily. And we compare that to the more classic pathway of dual antiplatelet therapy for 3 months, followed up with monotherapy. Unfortunately, the results were not not favorable for the rivaroxaban group in the long-term follow-up, and particularly you can see in this graph the antiplatelet group was significantly better and included the all-cause mortality that you can also see here, particularly in the long term, inclusive some mortality quite longer after drugs were discontinued. Bleeding was no surprise in this study. There was a trend, there was a major bleeding, a significant other types of bleedings higher with the low intermediate dose rivaroxaban. Interestingly enough, we also had, and this is the first time, a leaflet motion sub-study as assessed systematically by CTA has been subjected to a randomized treatment to see if it can be prevented by an alteration in therapy. And we saw in this, in our CTA sub-study, also published earlier this year in the New England Journal of Medicine, that although the dose of rivaroxaban was medium, as I said, and a lot of people were doubting its effectiveness, it was actually highly effective in preventing this CT finding. So good results with the prevention of the CT-based diagnosis of clots on the aortic valve leaflets. Nonetheless, clinical failure because of a higher clinical event rates, particularly the long-term mortality. We all await the results of the Atlantis in the next year regarding the utilization of apixaban twice daily with either Coumadin or dual antiplatelet therapy control groups, depending on the stratification about need or not of antiplatelet therapy. Again, this study is about 1,000 patients or 1,500 patients in the same league of the previous ones, and no definitive trial planned as of yet in this phenomenon. And let's move into the anticoagulated patients. And first of all, let me start with again a non-randomized yet interesting clinical outcomes of non-vitamin K oral anticoagulants versus vitamin K anticoagulants in a study from Germany that indicated in the series of patients that they studied, the non-vitamin K anticoagulants fared somewhat favorably compared to this warfarin, this non-randomized trial. In going to the randomized arena, the only study we have right now is the one published earlier this year in the POP-TAV investigators that starting pre-procedure, let me be very clear about that, oral anticoagulation plus clopidogrel versus oral anticoagulation, not interrupted by protocol. So a lot of people, probably most people, underwent TAVR with on uninterrupted anticoagulation. One can see the bleeding was in the range of 15 to even 30%, and one can explain that by the fact that all these procedures were performed on uninterrupted oral anticoagulation plus or minus clopidogrel, as well as some ischemic events. And then on the right side, you can see it's the same flavor. The clopidogrel addition to oral anticoagulation went particularly on the face of both uninterrupted administered orally pre-procedure, raised both types of events, particularly again in the first hospital period and early on. It's very clear that in hospital, day one, the results in bleeding was 10 versus 20%. That's like a lot of bleeding in my mind. And clearly, this feature of administering the therapies pre-procedure is something different than most people practice, in my view. But again, this study was designed and conceived at a time that everybody was very sensitive about possible strokes perioperatively or intraoperatively, and no wonder these investigators had some good reasons to believe that if we perform TAVR on a complete anticoagulation, you may be preventing events. This has since not panned out in the wake of the great advantages in device and technologies and techniques that have reduced dramatically dropped the rates of day one or day zero strokes. We have ongoing and completing the follow-up in our study, the envisaged TAVR in collaboration with Thorax Center in the Netherlands is 1,427 patients. The follow-up is completed the end of this year, and we hope to have the results, if not in European Society of Cardiology, definitely by the American Heart Association 2021, and that's going to be an interesting study randomizing patients into warfarin target 2 to 3 of INR versus a doxaban 60 milligrams, and as required, an adjustment down to 30 milligrams, all of it once daily. In for patients, obviously, who have somewhat decreased renal function, these adjustments indicate in the study in general, had about half and half those who require the full dose versus those who require the reduced dose based on the renal function adjustment. So in the midst of all these trials coming up and all the studies coming up and none of them being definitive, one can see that's no wonder the practice of what we give in our patients varies a lot, with a lot of subdivisions and individualization per hospital, per country, per hospital, and per doctor, or per patient, or per heart team, I should say. So in conclusion, we'd like to say that we reviewed the incidence of leaflet thrombosis after TAVR that indeed seems to be high, and its clinical implications are not well understood. Initially afraid of early strokes or TIAs, this doesn't seem to pan out at all in studies. And the situation that we faced is whether to this phenomenon is contributing to a limited or shorter valve durability, and how that could be studied and remedied. Clopidogrel loading before TAVR is associated with more bleeding and vascular complications without obvious benefit in stroke prevention. This has been clearly indicated, suggested by our study a couple of years ago, but clearly shown by a series of small yet interesting trials around the world. What happens after the procedure with clopidogrel or not is not clear at all, because the no study has particularly focused in the successful TAVI and what do you do afterwards. The current practice guidelines indicate a 3-month administration of clopidogrel after successful TAVR. This is very clear. In the experimentation with an intermediate or a lower dose than the one used in AFib with anticoagulation in patients not otherwise requiring this type of therapy didn't pan out as clinically beneficial in the Galileo trial. Nonetheless, Galileo CT sub-study also indicated that in order to prevent these types of microclots in the valve, you don't need to worry about high-dose anticoagulation. Even a medium dose can do the job pretty effectively. And going into oral anticoagulation, the monotherapy in general, based on non-randomized studies, seem to be favorable. In selected patients, the non-vitamin K anticoagulants have done well so far in the small studies. In the randomized arena, we can only quote, as of now, the POP-TAVI, and we wait for Atlantis and for Envisage TAVI AF in 2021, and albeit with a caveat that most TAVI procedures were performed on uninterrupted oral anticoagulation, the POP-TAVI can advise us that the monotherapy is interesting, and I don't think it's interesting and actually advisable. No clopidogrel use if the patient is needing anticoagulation and has no other reason for like a stent for the clopidogrel. But at the same time, I don't think anyone is following the protocol of the POP-TAVI and performing TAVI or TAVR procedures on uninterrupted anticoagulation. Pretty much everyone interrupts them a couple of days before the procedure and restarts them when it is safe from a vascular closure point of view, essentially upon a patient ready for discharge. So in brief, additional large-scale randomized evidence base is required to properly inform the guideline recommendations regarding particularly the type of antiplatelet therapy after a successful TAVR. And let's leave it at that for 2020, and we'll look forward for an update next year. Thank you for your attention.